Thank you, and thanks for joining today for this program on MASLD and MASH, specifically associated with lifestyle modifications for our patients in this population. So as I already alluded to, we're going to review a case directly guided at having a conversation and dialogue regarding lifestyle modifications for these patients, which is essential given the multiple metabolic comorbid conditions that they often have. I'm Jennifer Geremia. I currently practice in tertiary care at Brigham and Women's Hospital in Boston. And prior to that, I was in the community GI setting. So I've seen numerous MASH and MASLD patients over the years, and it's exciting to have an evolution of the ability to truly identify these patients and treat them. For anybody who needs it, this is the QR code for today's program for registration. And also, this is another scan code here if you want additional education specifically associated with disease state that's hosted by Madrigal that supports the GHAPP MASLD MASH Community Network. And there's also some resource material and promotional programs specifically to resmetirom. So let's jump into a case here. So this is a fairly classic patient that we will see across the spectrum, both in GI, primary care, really any discipline. I would say MASH affects all and every discipline of medicine, in particular internal medicine. And so we also don't want to have sort of a laser focused view that it's not in my purview to be identifying these patients because it very much, again, crosses the spectrum, in particular primary care, cardiology, endocrinology, anybody that's really seeing metabolic patients. So our case here is Albert, who's a 65-year-old male with obesity. So his BMI is 29. So he's actually right at the cusp of class 1 obesity. Technically, by BMI standards, would qualify as high end of overweight. He was referred to, in this case, GI for elevated liver enzymes, which is one of the most common referrals that we get in GI is transaminitis or isolated high alk phosphatase, whether it be isolated or persistent. And in this case, the primary care had the fortitude to, at a minimum, order the ultrasound. And an abnormal imaging study on the ultrasound revealed remarkable for increased echogenicity consistent with steatosis. Now, aging myself, going back early in my career, I was in internal medicine. And for a very long time, we sort of looked at this not so much as a variation of normal, but we just sort of said, hey, you do have some fatty liver, reduce alcohol use, try to lose some weight, and it wasn't that we were minimizing it. We just didn't really have very good guidelines or tools to help guide this conversation. And unfortunately, over the course of my career, I saw patients that ended up with end-stage liver disease. The last patient I actually sent for a liver transplant was a fatty liver patient. So certainly there can be some very real consequences. And the fact that it just sort of smolders there and doesn't cause any symptoms until there's end-stage liver disease is really the nefarious part of this. Looking at some lab values when he came in for the initial consultation, triglycerides were 89, nothing too remarkable. HDL 41, actually not so bad for a male. So he's diabetic, hemoglobin A1C of 7.2%. And he's had a persistently elevated ALT for about 3 years, so not insignificant, 1 to 2 times upper limits of normal. I also did not point out that he's Hispanic, and that potentially could confer some variations in course with liver disease based on genetics and racial backgrounds. And he underwent a full workup for chronic and acute infectious liver disease, right? So when these patients come to us with abnormal LFTs, we have to do a liver workup of all and any types, whether it be some outlying zebra or acute infections, etc. He says he's not drank any alcohol since his 20s. I think if there's a question of this, or it seems like the patient's a bit hesitant or maybe reports alcohol use, but you're still suspicious that they may not be entirely forthcoming, make sure to include PEth testing as part of your workup. He has 3 metabolic risk factors: type 2 diabetes, hypertension, and hyperlipidemia. On physical exam, he has some visceral or midline abdominal adiposity No stigmata of advanced liver disease. What would that really consist of? So suggestion of things like portal hypertension, so ascites, thrombocytopenia on labs. And again, BMI is just at that cusp of class 1 obesity. So looking at all of this, full liver workup was otherwise negative. He has transaminitis. He has multiple metabolic risk factors. We can confidently say to our patient, Al, you have metabolic dysfunction associated steatotic liver disease, or otherwise make it palatable fatty liver. And so what are we going to do with this information? And notice nowhere here did we order a liver biopsy. So that's the nice thing. We don't have to subject our patients to that consistently. So here are our labs. So platelets look okay, right? Some marginal transaminitis, nothing to really blink an eye at, but I think the key here is that this has been very persistent for Albert over the last 3 years. Fib4, whether it be done by yourself or primary care, endocrinology, whoever may be managing his metabolic conditions, is at a 2.2. So we know by AASLD guidelines that that's a reasonable starting point, although there can be some limitations accounting for age and LFTs. So based on this, this is elevated. And so if we look at that pathway, you know, how do we approach different non-invasive testing paradigms and try to implement them in our day-to-day practice? So fortunately, I am in an institution that FibroScan is very readily available, but I also came from a community background. So I also appreciate the limitations in being able to access FibroScan, especially if you're not in the GI space. So as the guidelines really guide us, right? So we want to be evidence-based, guideline-based in terms of how we approach this, whether it be primary care, endocrinologist, GI, cardiology, anyone. Again, I would say every specialty across the board, specifically in internal medicine, will see these patients. So you have this patient in front of you who clearly checks the boxes for risk. And in this case, 2 or more metabolic risk factors. Type 2 diabetes by itself does not have to be one of the two, can be just one in of itself, because that's a risk factor for fibrosis. And any incidental steatosis on imaging. Perhaps the patient came in with right upper quadrant pain. The consult wasn't even necessarily associated with liver functions, but we stumble on steatosis. Maybe the patient's coming in for you for complaint of GERD. And, oh, by the way, you have these risk factors. So I sort of liken it to a patient that comes into me that needs a screening colonoscopy. Maybe their primary consultation, again, was for foregut symptoms like GERD, but I'm not going to be remiss in saying, hey, by the way, you're 45, have you had your colonoscopy, right? So I would treat this in the same vein. And also any persistent elevations in transaminases or abnormal liver functions. Thorough history of alcohol consumption, medications, and supplements. That's always very important in terms of identifying for potential drug-induced liver injury. CBC, of course, to check platelet counts, make sure that there's no thrombocytopenia, and a full liver function panel. So maybe they came in with just a CMP, but really that full panel. And if they had high ALK phos, also tagging on that GGT. So what are our next step there? Again, I think anyone who does not have easy access to FibroScan, or you just want to do a quick screen on the patient, go ahead and calculate that Fib4. You can do that on a variety of apps on your phone. You can easily integrate the Fib4 into your EMR and your templates. So Epic, you can do a dot phrase, for example. And again, this is what our guidelines tell us to do. And so this takes into account patient age, AST, ALT, and platelet count. And we understand that this is not a perfect tool, but it is a starting point, right? There's limitations to all and every NIT, but we need a starting point. And so again, there will be some variability, but this is where we start. And based on the ranges here, Fib4 less than 1.3, we can have some reasonable confidence that, okay, there's no fibrosis here, again, assuming that they don't have any persistent elevated LFTs. For our patient Al, right, he was on the higher end of this indeterminate range, where the high end is being 2.6, he's 2.2. Then anything above 2.67, we worry for more advanced disease. Really, if you fall in this indeterminate box, is when you should then reflex to your next level of non-invasive testing, which the recommended test is going to be elastography. So whether that's FibroScan, ultrasound elastography, again, understanding the limitations and availability. So if you don't have good access to that, you can also order serological ELF testing. There is also MR elastography, but that generally wouldn't be your next, your first NIT after Fib4. So based on what their liver stiffness measurement would be, so looking here, anything under 8 with a, we can say, okay, let's follow this up potentially in 2 to 3 years, unless there's some clinical change in their course. In my practice, I do Fib4s yearly, personally, and reassess whether or not we need to do another FibroScan. If they fall in the 8 to 12 category, they're considered a moderate risk individual and really should then be referred out if you're not in the GI space at this point for management. And where do we go from here? If the quality of the exam is good, there's no other aberrancies in terms of concomitant liver disease, we can feel confident in treating that patient. Again, not everybody needs a biopsy unless there's either the potential for multiple causes of liver disease, quality of exam was poor. In that case, I would probably just reflex then to an MRE elastography versus subjecting the patient to a biopsy. And again, reevaluating them at short interval. We tend to do it 6 to 12 months. Guidelines tell us it is okay if they're stable for 2 to 3, and definitively if there's suggestion of advanced liver disease, F4 or cirrhosis, that they need to see hepatology for proper management. So he is in that indeterminate risk, and as I already alluded to, we then go to some form of evaluation for liver stiffness measurement, in this case, elastography, and so he was a 6.7, so he is now considered in that lower range. And so conversation here is not so much about pharmacotherapy for fatty liver, of course, pharmacotherapy for his metabolic disease management, diabetes, hypertension, hyperlipidemia, but really also engaging in lifestyle modification. I often say, whether it be related to obesity and weight management or these metabolic conditions that are often weight driven, that, weight loss is like legs of a stool, and each leg has to be even for that stool to stay upright. And lifestyle is always one of those legs of the stool. So it is not a passive process. So when we've identified someone as being overweight or obese, have type 2 diabetes irrespective of BMI, and are overweight and obese with 2 or more metabolic conditions, it's sort of priming them to set them up for steatosis and sort of this continuum leading to cirrhosis. And cirrhosis is the leading cause in women for liver transplantation and second all-cause for transplantation. So we know that there is impetus to identify and treat and monitor because of the consequences of morbidity and mortality from cirrhosis. So steatosis, as we see sort of in our arrows here, there's a chance to reverse this process. Steatohepatitis is when there's inflammation related to that steatosis, so not just the simple presence of steatosis by whatever imaging or biopsy, etc. And then we have fibrosis, and if we really identify patients in the range of F2-3, we can reverse course, which is really quite remarkable, right? Because more often than not, what we do in sort of healthcare is management, but can we actually reverse a disease course? And that's really exciting to be able to do. But we also know if we don't reverse it in that 2 to 3 range or less, right, that once they hit F4, we cannot reverse course because the liver is too scarred and nodular. We also know that advanced fibrosis and cirrhosis puts patients at risk for hepatocellular carcinoma, which we know can be a death sentence for these patients with very high morbidity and mortality. So what other sort of risk factors and genetic processes are occurring in the liver that ultimately lead to this, right? Because not all in every diabetic, not all in every patient is going to have fatty liver with fibrosis. We even see lean fatty liver, excuse me, right? So what's sort of happening from a pathogenesis standpoint? So some genes here have been identified that when there's some dysregulation can put the patients at risk. And this is just more for your knowledge base. There's no testing per se that we do, regularly or what have you to identify this. So we know the lifestyle part, right? Patients with a high saturated fat diet are just inherently at an increased rate for inflammation and, of course, steatosis and increased risk of radical oxidative state. Fructose, we know, increases lipogenesis, reduces fatty acid oxidation, and again, further increases that oxidative stress. So from a gene pathway, when we look at this first gene, the PNPLA3, reduces what is known as TAG hydrolysis. And TAG is a triglyceride transporter that works in trying to signal to have fat and cholesterol leave the liver and enter into the systemic system. We also know that VLDL works in this pathway of secretory pattern of the fats leaving the liver and going into the circulation. So if you have a reduction in hydrolysis, so breakdown of fats, and also a reduction in that transporter pathway carrying the fats or cholesterol out of the liver into circulation, that it's just going to sort of sit in the liver, right? So that's fairly intuitive. Reduction in breakdown and reduction in secretion or transport. Now, looking at this next genetic marker here, MBOT7, when this is dysregulated, can result again in problems of reduction in fatty acid oxidation, and also can promote de novo lipogenesis, so more production of lipogenesis. And also when you reduce TLR signaling, this is part of our macrophage pathways. And so when this is reduced, there's more inflammation and release of cytokines within the parenchyma of the liver. So you need a good, nice, robust TLR signal to help as a protective factor. And in this case, it's reduced. And then there's an increase again in oxidative state, ROS generation. So increase in oxidative state, reduction in protective signaling in the TLR. And so that now we have a mismatch there. And then if we look at this last gene, when dysregulated, TM6F2 reduces VLDL particle size. So I've already referred to that sort of transporter system to carry cholesterol out into the circulatory system. So if that is smaller, you can't carry as much of that fat or cholesterol out of the liver. Okay. Point being, when there's dysregulation in this genetic pathway, plus the combination of lifestyle, the presence of steatosis occurs, inflammation, hepatitis, and ultimately cirrhosis. We know inflammation causes permanent damage anywhere along the body, regardless of which organ system we're talking about. And we look at dietary fats, not all omega fatty acids are created equal. There's lots of commercials and supplements for good omega fatty acids. And if we sort of look here, that omega 6 fatty acids can actually be a contributory factor, where omega 3s are protective. In this, again, vein of pathogenesis, we know obesity with associated type 2 diabetes is one of the biggest risk factors. And we know it's there, but yet seems to fall under the radar, even though it is, as enumerated here, the elephant in the room. Often I say, we do a really good job with our diabetic patients, and we have all these health maintenance checkoffs. Did you see your eye doctor to make sure there's no diabetic eye disease? Have we done your creatinine and your spot proteins to make sure that your kidneys are healthy? Did you see your foot doctor to make sure that that's all in check? But somehow the liver gets forgotten in that whole discussion. And so what we really need to do is add the liver to our health maintenance check sheet for our diabetic and metabolic patients, because we do, again, a really good job at checking all these other things, but we need to just throw in that FIB4 at a minimum and make sure that that is part of your health maintenance check sheet in patients with metabolic disease, and in particular with diabetes. So balance between nutrient intake and energy expenditure, of course, is crucial. We know that that's the mismatch that happens in obesity, right? And in particular, central obesity or visceral adiposity is one of the major promoters of insulin resistance and pro-inflammatory signaling, both because fatty cells and visceral hypersensitivity have increased cytokines and are actually attaching to our abdominal organs, such as the liver, pancreas, and colon, but also the peripheral insulin resistance mismatch that's happening there. And the person is increasingly secreting endogenous insulin, but yet their body is not detecting that, further resulting in weight gain. So with Albert, really getting granular. And I do this with my patients in terms of dietary questioning. I ask them, what is a typical day like? Tell me what breakfast, lunch, dinner, and snacks are like. And, you know, what tell me what was yesterday was like, just what's an average day, right? We don't need expansive logs and apps, just what happened yesterday, right? And so he went on to say that he's Cuban in origin and he follows a traditional Cuban diet consisting of rice, beans, pork, corn, beef, and plantains. And so you have to know where they're starting from to know where you're going. We can at nauseam say eat more fruits and vegetables, lean proteins, but we have to take into account where they are, what they're willing to eat, what they like to eat. And also, you know, this is also a tougher discussion, but really what do they have access to, right? We can't be remiss and recognize the economic factors of eating well and how you get access to things due to cost, but also just I'm busy, right? And so my inclination is to get fast food because I'm busy, right? So you have to first know where are you starting from? Where are they at? And where can we then modify that? And so we then have to tailor it based on all of these factors that I just listed, right? And so, for example, with vegetables, do they like vegetables? Do they not like vegetables? So do we need to go on to a different source of fiber, whether it be whole grains, oatmeal, etc.? Where can we get good sources of protein if they don't eat a lot of animal meats, right? Again, really meeting them where they are, engaging a nutritionist can be helpful. And, you know, maybe we're not cutting them down to 1,000-calorie diet if they're on a baby steps, do this gradually, so that this really can be a long-term change for them that they can easily adapt to. And I think the other important piece is not saying you can never eat the things you like. It's just a matter of how you reasonably incorporate that into their treatment paradigm. I always say, I'm not limiting you to not have anything. We just need to find some good balance here, right? And so I think if they also know that they have some flexibility can be helpful. So again, he's been diagnosed with MASLD here. So we know in terms of weight management, right, that we really need a minimum of 7 to 10% reduction in total weight loss from baseline that is maintained. The challenge is we can usually get them there, but the long-term maintenance of that. And you really need that persistent long-term maintenance to make sure that the steatosis and any associated fibrosis stays abated. So apart from the dietary modifications, so high protein, and we talk about protein ad nauseum, but we never explain why. It's really essential for good protein, not just for satiety, but to prevent things like sarcopenia and muscle mass loss. And I explain that to my patients. And I tend to use the word activity over exercise because I think society, we sort of have this imprint in our brain that exercise has to be very aggressive. You have to go to the gym every day and be Ironman, and it doesn't, right? So we just need to repivot that. And so we need about 150 minutes per week of both aerobic and non-aerobic activity. And this was the mainstay of treatment prior to resmetirom being approved. And again, we know that lifestyle modifications can improve histological outcomes, as I mentioned earlier, about weight reduction and that percentage needed to resolve steatosis and the antifibrotic effect. So framing kind of goals. When I talk to patients, I talk to them strictly within this realm of percentages of weight loss. I don't talk about their goal number. That is a completely arbitrary number. So we really put into context what's meaningful here. And why do we treat weight management? It's not for vanity. It's not for a goal number. It is about reduction of risk of comorbid conditions. Okay, so sometimes we have to level set with the patient as well. And so the efficacy of diet and exercise treatment, again, may be impacted based on genetic polymorphisms. We talked a little bit about that. And we're going to look at sort of the activity or exercise piece here in a moment. So we know a good anti-inflammatory Mediterranean diet, lean proteins, high fruits and vegetables are particularly helpful here, and reductions in sugars. So not all activity is created equal, right? So patients that are doing just weight-based exercise, so bodybuilding or just resistance bands or just weights or things like high-intensity interval trainings are not as effective, in particular for fatty liver. It doesn't mean it doesn't help with muscle mass building, which has its own benefits, but it has to be a marriage, right? So we need actual energy consumption with aerobic exercise. And with resistance exercise, again, helps with building up muscles so patients don't develop atrophy, etc. And it can help with some caloric burning at, just sort of at rest. But apart from that, it doesn't really provide the activation of reduction in basically apoptosis of the fat cells, right, to reduce steatosis. Also, aerobic exercise increase a variety of cytokines, so uncoupling protein and also PPAR. We've heard of PPAR in the space of the liver related to PBC. It has anti-inflammatory factors, but aerobic exercise naturally upregulates this without any type of medications. So we do need, again, that combination of the aerobic and anaerobic, and again, about 150 minutes per week, the combination of both. And I try to meet the patient where they can. Maybe it's a 10-minute walk today, and maybe on the weekends, it's 30 minutes. Maybe it's some resistance bands and YouTube Pilates, right? So meet them where these goals are attainable. It doesn't have to be the gym, and it doesn't have to be aggressive. As I mentioned earlier, caloric restriction is the paradigm in terms of weight loss is the mainstay. And always revisit this, and it's a challenge, and use your resources of nutrition, hopefully where you can. Promotion of ketogenesis, both through diet, is another method here, taking into account genetic predisposition and also patients' ability to respond to specific diet modifications. Again, we can talk to them ad nauseum about diet, but if you don't ask them what they actually like, are willing to eat, and what they have access to, you're no better off for the wear. We know that multiple governing bodies really support the Mediterranean diet specifically. So AASLD, ACE, and EASL guidelines recommend this as the primary dietary modification. Albert returns for his follow-up with really no change in his labs, and he admits he has not done any activity or exercise, but is trying to cut out sugary sodas. And so how do we work with patients to create behavioral change? So again, it's a mountain to climb. It's not a switch that we flip. Is there potentially a stress or anxiety component to their eating? So do we potentially need to engage cognitive behavior therapists? We really just have to get a little bit granular and not just throw the information at them and say, well, okay, well, what's the biggest challenge that you have here? How come, right? Why haven't we been able to make some progress here? There are some adherence validation tools that are available in a variety of different scales. We're looking here at exercise and diet adherence scale, which the patient fills out the questionnaire, typically at about a 6-month interval with different criteria to really, so this is going to really monitor so more like a logging concept of daily exercise and caloric intake, because sometimes I think patients also underappreciate potentially where their limitations are, right? So maybe they're rationalizing some of their behaviors, and, oh, I only ate the cookie today, but really it's been over the last 6 weeks every day, right? So sometimes those things can be helpful in terms of level setting as well. And, any incremental progress, even if it's 3 pounds, congratulate them on that, right? It's not a huge percentage, but say, hey, good job, or even if they didn't regain, right, or gain weight, say, look, at least you're sort of stable, right? So let's build on that. And so sort of validating any little wins that they have can also help with adherence. So thank you for joining me today on discussing lifestyle modifications for MASLD and MASH patients. Have a great day.